So grossly, if you look at the leiomyoma, like any other benign tumor, they are typically well circumscribed, multiple, as we can already see. So they are very well circumscribed. Okay, so this is suggesting that they are basically what kind of tumor? They are a benign tumor. Okay, and also they are multiple. See, we can see multiple tumors in a single uterus. Now the cut section, if you cut the leiomyomas, if you see, the cut section is classically whorled. Whorled means this kind of appearance. Okay, round. So there's a whorling, there's a whorled appearance. Okay, there's a classical whorled appearance. Okay, and remember, on cut section they have a firm rubbery consistency. Okay, so they are having a rubbery consistency. Now also, when you cut these tumors, they have a prominent bulging surface when you incise the tumor, thus releasing the intratumoral pressure, and this is also characteristic of leiomyoma. Now the larger tumors might show areas of infarct and hemorrhage, and this is like any other tumor. Any other large tumor can show infarct and hemorrhage. Sometimes cystic changes can also be present. Now remember, in pregnancy they can have a beefy red appearance. Okay, this is called as red degeneration. These are about the gross features of uterine leiomyoma. Let us try and understand what is stump. Now let me just make it very clear. On the benign end, or at one end, we are having leiomyoma, and we have also seen certain criteria for the diagnosis of leiomyoma. On the malignant end, we are having Leiomyosarcoma. Okay, this is the malignant end. Now, what was happening? This is the malignant end. Okay, so now what was happening, that there are certain tumors, okay, which are not falling under the category of leiomyoma, and there were certain tumors which were again not falling under the category of leiomyosarcoma. Such tumors were labeled as stump. STUMP, which stands for smooth muscle tumor of uncertain malignant potential of the uterine corpus. So what is the criteria for the diagnosis of the conventional spindle cell variety of uterine leiomyosarcoma? There should be presence of marked cytological atypia, grade 2 or 3 nuclear atypia should be there. There should be presence of tumor cell necrosis. Now the criteria for tumor cell necrosis is given and discussed over here. Then there should be mitotic figure should be equal to 4 mitosis per millimeter square, that is equivalent to more than equal to 10 mitosis per 10 high power field. This is very important diagnostic criteria, and out of this 3, 2 should be at least present. So this, you can see the spindle cell leiomyosarcoma, you can see the intersecting fascicles, but the fascicles over here are not at all organized. So they are quite disorganized. And you can see the nuclear atypia. Very importantly, you can appreciate the nuclear atypia. Now, very importantly, you can see the tumor cell necrosis, and you can also appreciate there is a sharp distinction between the two. Okay, there is a sharp area of division between the two. Okay, this is the tumor cell necrosis. As we can appreciate the tumor cell necrosis. Not only this, there will be an increased mitotic activity as well. Now, this is the characteristic geographical areas of necrosis. The areas of necrosis are quite irregular, as if some map. Okay, that is why we are calling it as geographical areas of necrosis, and they are quite well defined, as we can appreciate, and they have irregular angulated border of necrosis, which is characteristic of tumor cell necrosis. Again, in the WHO, as we can appreciate, the tumor is highly cellular, as you can see from this diagram, and you can see so many enlarged hyperchromatic nucleus at low power magnification only you can see. Okay, then the second image, you can see how much there is a sharp interface between the tumor cells and the tumor cell necrosis. Thus, it is suggestive of tumor cell necrosis. Okay, and very importantly, if you see, significant tumor pleomorphism is present and very high mitotic figures is there. That is more than 4 per millimeter square or more than equal to 10 mitosis per 10 high power field. At least out of these 3, 2 should be present for diagnosis. Myself, Dr. JIBRAN presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to read about the tumors which are arising from the myometrium, okay, uterine myometrium, and this is mainly based on WHO 5th edition of female genital tract, FGT. So let us look at the classification of the tumors of the uterine corpus. So basically, if you see, the tumors of the uterine corpus or the uterus is divided under separate headings like endometrial epithelial tumors and precursors, tumor-like lesions, then mesenchymal tumors specific to the uterus, mixed epithelial and the mesenchymal tumors, and along with that we are also having certain Miscellaneous tumors. Now, if you look under the heading of the endometrial epithelial tumors, we have already discussed in details about the endometrial lesions in other lecture. And in today's topic of discussion, what we are going to understand, we are going to concentrate on the tumors which are arising from the uterine myometrium. For example, the Leiomyoma uterus, which is one of the most common tumors arising from the uterus. Then intravenous leiomyomatosis, then what is called as stump. Stump is the smooth muscle tumor of uncertain malignant potential, also called as STUMP, which are of three main types: epithelioid, myxoid, and spindle variety. Then we have metastasizing leiomyoma and leiomyosarcoma NOS, which again can be spindle leiomyosarcoma, epithelioid, and myxoid varieties. So these are the major topic of discussion that we are going to discuss today. So let us begin with the first topic of discussion, that is the Leiomyoma uterus. So if you see that the Leiomyoma uterus has certain molecular alterations like mutations in the MET12 gene, HMG A2 and A1 gene mutation, COL4A, 5 and 6 mutation, and mutation in fumarate hydratase gene. So basically, MET12 mutation is seen in 70% of the cases, whereas HMG-A1 and 2 mutation is seen in 25 to 29% of the cases. COL4A5 and 6 mutation is seen in 4% of the cases, and FH mutations in the fumarate hydratase gene is seen in 1% of the cases. Now, in addition to these common mutations, we are also having alterations in 7q22 deletion, 22q as well as 1q deletion. So these are the other alterations which are seen in leiomyoma. Now clinically, if you see the uterine leiomyomas, that is also called as fibroids or myomata, they most commonly occur in the reproductive age group women, usually in the 5th decade of life, and they are benign neoplasms arising from the smooth muscles of the uterine wall. Now if you look over here, the leiomyomas or the uterine leiomyomas, they are the most common uterine tumor. Its subtypes. Now if you see uterine leiomyoma, they have different types or different subtypes. Okay. Now its subtype is constituting only 10% of the uterine leiomyoma. Remember, the subtypes of leiomyoma is constituting only 10%. Okay. Now although leiomyomas, they occur very frequently, but the patients present very less with clinical features. Okay. What do I mean by that? I mean that if there are 100 patients suffering from uterine leiomyoma, maybe only 25% will present clinically. Okay, so leiomyomas result in clinically apparent and symptomatic cases only in 25% of the women. Okay, so what are the clinical symptoms or the clinical sign symptoms? Okay, those patients which are presenting with clinical sign symptoms include abnormal uterine bleeding, pelvic pain and pressure, as well as infertility. Now, what are the risk factors for the development of tumors? They are: number one, race and parity. So, black and nulliparous women are more likely to be affected as compared to other race and multiparous women. Now, leiomyomas, they are also hormonally responsive and dependent tumor. How do we prove that? We can prove that why leiomyomas are hormonally responsive. How we can prove that? Because they are extremely rare before puberty, they regress after menopause, they may exhibit rapid growth with exposure to an altered hormonal state such as pregnancy, or when any treatment is started like clomiphene or progestin therapy. Now, the tumor cells are also expressing hormone receptors like estrogen and progesterone receptors. So all these associations prove that these tumors, that is the leiomyomas, they are hormonally responsive and dependent tumors. Other risk factors for leiomyoma, apart from race and parity, that is in blacks and nulliparous, apart from that, includes positive family history, a premenopausal state, hypertension, and more than 5 years since the last birth. Now, there are also certain genetic predisposition leading to the causation of uterine leiomyomas. Okay, because we see that leiomyomas, they are more common in black women. So certain genetic factors must be there that is predisposing the black women to have increased incidence of leiomyoma. Also, they can occur as a part of hereditary leiomyomatosis renal cell carcinoma syndrome, also called as HLRCC syndrome, also known as Reed syndrome. They are also called as Reed syndrome. Now, this is basically an autosomal dominant genetic disorder characterized by multiple cutaneous and uterine leiomyoma. So, in this syndrome, not only you are having leiomyomas affecting the uterus, but they are also affecting the skin. So there are multiple cutaneous and uterine leiomyomas, and they are autosomal dominant genetic disorders. Okay, and basically it occurs because of mutation in FH gene, that is fumarate hydratase gene on chromosome number 1. Usually the tumor occurs in lesser age as compared to the sporadic tumors that over here they occur in second to third decade of life. So genetically, remember, leiomyomas, okay, they have genetic associations also, like hereditary leiomyomatosis and renal cell carcinoma syndrome, that is the Reed syndrome, which is an autosomal dominant genetic disorder wherein you are having not only uterine leiomyoma but also multiple cutaneous leiomyomas. Okay, and basically the mutation occurs in the FH gene located in the chromosome 1, and the tumor occurs at a lesser age in second to third decade of life. So grossly, if you look at the leiomyoma, like any other benign tumor, they are typically well circumscribed, multiple, as we can already see. So they are very well circumscribed. Okay, so this is suggesting that they are basically what kind of tumor? They are a benign tumor. Okay, and also they are multiple. See, we can see multiple tumors in a single uterus. Now the cut section, if you cut the leiomyomas, if you see, the cut section is classically whorled. Whorled means this kind of appearance. Okay, round. So there's a whorling, there's a whorled appearance. Okay, there's a classical whorled appearance. Okay, and remember, on cut section they have a firm rubbery consistency. Okay, so they are having a rubbery consistency. Now also, when you cut these tumors, they have a prominent bulging surface when you incise the tumor, thus releasing the intratumoral pressure, and this is also characteristic of leiomyoma. Now the larger tumors might show areas of infarct and hemorrhage, and this is like any other tumor. Any other large tumor can show infarct and hemorrhage. Sometimes cystic changes can also be present. Now remember, in pregnancy they can have a beefy red appearance. Okay, this is called as red degeneration. These are about the gross features of uterine leiomyoma. Now we are going to discuss the microscopic features of the usual type of leiomyoma, and after we discuss the usual type of leiomyoma, we are going to discuss the different subtypes of leiomyoma according to the latest edition of WHO, and also the criteria we are going to see. So the usual type of leiomyoma, as we can see, they exhibit classical features of a smooth muscle differentiation comprising intersecting fascicles of spindle cells, which are bland spindle cells, okay, with eosinophilic cytoplasm, well-defined cell borders with bland elongated nucleus with blunt end. So if you look over here, you are having fascicles. So this is one fascicle over here, another fascicle is running here, another fascicle is running over here. So multiple fascicles of bland looking spindle cells are intersecting each other. If you look at the nucleus, they are having a very bland morphology, and the ends, if you see, they are blunted ends. So this is looking like a boxcar or cigar shaped appearance of the nucleus. Okay, so very bland looking nucleus without any kind of atypia. So mitotic activity is quite variable and often increased during the secretory phase of the menstrual cycle, but usually it is less than 5 per 10 high power field, which is the diagnostic criteria for a leiomyoma or for a benign smooth muscle tumor that we are looking at. So this is the leiomyoma. As we can see, the bland spindle cells with bland nuclear morphology with eosinophilic cytoplasm, and the individual nucleus, they are having boxcar or cigar shaped appearance like this, which is a bland appearance. Okay, the usual type, we can see the intersecting fascicles of bland looking spindle cells. Now the first variant of, or the first subtype of leiomyoma is the cellular variety of leiomyoma. So the basic definition is not precisely defined and it is rather subjective. So the definition given by the WHO is that cellular leiomyomas are significantly more cellular as compared to the surrounding myometrium or as compared to the usual variety of leiomyoma. Also, there will be presence of thick walled vessels and cleft-like spaces in this variety. Cellular leiomyomas, just like the usual variety, they also have a uniformly bland cytomorphological feature. So again, they will have the usual intersecting fascicles of bland looking spindle shaped cells. Okay, but these cells, they are having a more scant cytoplasm, and the mitotic activity is typically less than 5 per 10 high power field. Okay, so it is less than 5 per 10 high power field. If you compare again this leiomyoma, again you can see the fascicles. Okay, so there are different fascicles. So you have intersecting fascicles of spindle cell. But what is different? If you compare it with the usual variety, you will see that the usual variety, look at the cellularity of the usual variety and compare over here with this cellular variety. Basically, you can see that the cellularity is more as compared to the usual type. But the other features are same. Okay, they are all bland looking cells. Okay, so they do not have any atypia, and even the mitotic figures are just like the usual variety. So everything is same like the usual variety, except the cellularity is more in comparison with the usual type or in comparison with the surrounding myometrium. Just one thing over here, the cytoplasm is scant as compared to the usual type. That is why the nucleus over here is looking a little bit bigger. Coming to the next subtype of leiomyoma, this is a leiomyoma which is having bizarre nucleus. This is also called as symplastic variety of leiomyoma. Now again, you have to understand, just like the usual variety, they basically all the features are like the usual variety, except that there is presence of certain cells with enlarged pleomorphic and multiple nucleus, and also hyperchromatic, and this change can either be present in one focus, in that case we call it as unifocal, or there can be multiple such focus of pleomorphic cells called as multifocal variety, or they can have a diffuse throughout the tumor, diffusely such cells are present, okay, in the distribution. Okay, and in the background you will have a normal leiomyoma. So apart from these cells, everything is normal. Okay, these pleomorphic cells also may have abundant eosinophilic cytoplasm. They also have nuclear pseudo inclusions, and they have a coarse hyperchromatic chromatin. If you look at this particular diagram, again all the features are like the usual type. They are having intersecting fascicles of spindle cells, except that there are certain pleomorphic cells with coarse chromatin, presence of nuclear pseudo inclusions, and they have abundant cytoplasm, and sometimes they can be multinucleated as well. So these bizarre cells, okay, they can be present. Pleomorphic bizarre cells are present. Apart from that, if you see, the mitotic activity is less. It is again less than 5 per 10 high power field, just like the usual variety of leiomyoma. Okay, now in this variety, if you see, this is the diffuse variety, wherein the pleomorphic nucleus is uniformly distributed. So this is the atypical leiomyoma with bizarre nucleus, which is enlarged pleomorphic nucleus, which are diffusely present throughout the tumor. Now the next variety is the fumarate hydratase deficient leiomyoma. Now this is one variety, if you see, which is showing a typical staghorn vessels or staghorn vasculature. As you can appreciate over here, the vessels are staghorn shaped like this. Okay, they can be staghorn shaped like this. Okay, like this, for example, they are staghorn shaped. Okay, apart from that, they also have edema, which is alveolar type of edema. Okay, so they have alveolar type of edema, as we can appreciate. They may have bizarre nucleus, as we can appreciate from this diagram. But most importantly, they have large vesicular nucleus with a prominent nucleoli, as you can appreciate. They have a prominent nucleoli. Not only that, there is a perinucleolar clearing. What do you mean by this? If this is the cell, this is the nucleus, and over here the nucleoli is this. So around the nucleoli there is some clearing, that is perinucleolar clearing. Along with that, sometimes cytoplasmic eosinophilic inclusions might also be present. Histological features are similar in both the sporadic as well as the familial variety of FH deficient leiomyoma. So what is the meaning of this? So even in the sporadic cases where there is a loss of FH, and even in the familial cases, okay, where there is FH deficient leiomyoma, which basically occurs in association with hereditary leiomyomatosis along with renal cell carcinoma syndrome. So in both the sporadic as well as in the hereditary case, the histopathology is the same, or the histological features is the same. Okay, this is another diagram, as I can show you over here. You can see epithelioid, you can see vesicular nucleus with prominent nucleoli, and around the nucleoli you can see perinucleolar clearing, as we can appreciate. Around the nucleoli there is clearing. They also have abundant amount of eosinophilic cytoplasm. Sometimes eosinophilic inclusions, as we can appreciate, also called as rhabdoid inclusions, can also be present, and this eosinophilic material can both be in the cytoplasm as well as extracellular as well, as we can see in this diagram. Now this is the immunohistochemistry, where we can see loss of FH. So immunohistochemistry was performed with fumarate hydratase staining was done, and there was complete FH loss. If you look at the tumor cells over here, these are the tumor cells which are negative. They are showing negative staining for fumarate hydratase. Whereas this positive cells, as you can see, these are nothing but the blood vessels which have stained positive for FH, but the tumor cells have stained negative for the FH. And this kind of morphology, FH deficient morphology, is characteristically associated with hereditary leiomyomatosis and RCC syndrome. And not only this FH association can also occur sporadically. Okay, both sporadic as well as it can occur hereditary. Okay, so this is all about the fumarate hydratase deficient leiomyoma. After this, we are having mitotically active leiomyoma. Over here, as the name suggests, that this leiomyoma is mitotically active. That means the mitotic activity is greater than 5 mitotic figures per 10 high power field. Okay, and very importantly, it is less than 15 mitotic figures per 10 high power. So it is in the range of 6 to 14 mitosis per 10 high power field. This is the criteria for mitotically active. Apart from increased mitosis, all other features are similar to the typical usual leiomyoma. They have bland cytomorphological features. There is no tumor necrosis. There is well-defined cell margins. All these features are the same. Now, these tumors may occur over a wide range of age. In contrast to the leiomyosarcoma, these tumors occur over a wide age range, and they are typically seen during the reproductive age with a mean age in the 5th decade of life. Now, the increased mitotic activity can occur or is attributed secondarily to hormonal influence, because these tumors are commonly seen in association with pregnancy or hormonal therapy. After that, we are having leiomyoma with hydropic degeneration. What do you mean by hydropic degeneration? There is accumulation of edema fluid, okay, and this is called as hydropic change. And the edema fluid can accumulate both focally, that is in one area, or diffusely, resulting in a corded or nested pattern. Now, with extensive amount of this hydropic change, the gross appearance of leiomyoma may mimic either a myxoid smooth muscle tumor because of the glistening cut surface, or intravenous leiomyomatosis as a result of protrusion of the smooth muscle bundles. So very importantly, because because so much amount of water has accumulated, so on cut section they might give a myxoid appearance. Thus, you might think it is a myxoid smooth muscle tumor. And not only that, on cut section you can see see protruding smooth muscle bundles. So in that case, you might see that the smooth muscle bundles are separated by the edema fluid into adjacent areas of cavitation. So it might mimic that the muscle bundles are invading a particular vein. So you might get confused with an intravenous leiomyomatosis. So this is the classical diagram as we can appreciate over here. So because of the accumulation of edema fluid, you can see these smooth muscle bundles, they have separated from each other. Okay, and it is giving an appearance that it might be an intravenous variety. But for proving that, you have to prove histologically the presence of invasion in the vessels. So this is the hydropic leiomyoma. We can see separation of the muscle bundles by accumulation of the edema fluid, which produces a multinodular appearance as we can appreciate. Okay, and the differential diagnosis for this is the intravenous variety of uterine leiomyoma. Now, histologically, there is intercellular accumulation of edema fluid, and this fluid is often pale and more eosinophilic compared to the myxoid change that we see. And usually it occurs in a characteristic perinodular distribution. That means the fluid will accumulate around the tumor, forming nodules. So this is the perinodular pattern that you see. Okay, so let me show you in this particular diagram. So this is the edema fluid, which is quite pale over here. This is the edema fluid over here, and it has basically, it is surrounding this tumor. Okay, this tumor growth, it is surrounding. So it is giving a perinodular appearance. This is giving a perinodular appearance, which is characteristic. This is another image given from the WHO. If you see, this is the pale eosinophilic edema fluid, which has basically separated this entire tumor into multiple nodules or even cords and even nests of tumor cells. Okay, not only this, over here the edema fluid is basically forming round nodules. Okay, so they have surrounded the tumor nodules and they are forming tumor nodules, giving a perinodular appearance. Okay, this is a perinodular hydropic change in leiomyoma, the second diagram. Okay, now what are the features that are favoring hydropic degeneration? The generally well circumscribed nature of the tumor, absence of smooth muscle bundle protrusion into endothelial line spaces, very important. Okay, it helps to distinguish the leiomyoma with extensive hydropic degeneration from intravascular leiomyomatosis. Next, we are going to discuss about the apoplectic variety of leiomyoma. As you can appreciate, there is a stellate zone of hemorrhage. Stellate means there is star-shaped zone. of hemorrhage. There is a zonation phenomenon. That means apart from this area, the background will be typical uterine leiomyoma. Okay, and very importantly, at the interface, you can see certain rim of increased mitotic activity at the rim, at the juncture. So there is a zonation phenomenon which is present with otherwise typical background of leiomyoma associated with progestogen therapy or pregnancy. Now, the central zone of hemorrhage, as we can appreciate, the central zone of hemorrhage and necrosis as well as infarction, not necrosis, central zone of hemorrhage and infarction, which is surrounded by a hypercellular rim of cell and may show increased mitotic activity, as we can appreciate in this diagram. Next is a very simple variety. There is a lipoleiomyoma. Now, in the background of usual bland spindle cells, you can see abundant adipose tissue. So, this is abundant fat or adipose tissue in the background of usual leiomyoma. Okay, this is what it is. Okay, so we can see the presence of variable number of adipocytes admixed with smooth muscle cells, which when numerous results in yellow discoloration on gross examination. Most patients of this variant, they are postmenopausal women. Okay, so this is basically raising the possibility that there can be alternative form of differentiation is possibly degenerative in nature. Now, we have also seen certain rearrangements which can be mapped to this HMGA2 gene in this particular variety. Then we have the epithelioid variety of leiomyoma. The WHO defines this variety as a tumor which is composed of epithelial-like cells. The patients with the epithelioid variant of leiomyoma, they do not differ in their clinical manifestation from those of the usual variety of leiomyoma, being most often affected during the reproductive years. On gross examination, the tumor may appear different from the usual type of leiomyoma. So they have a more soft consistency and they have a tan or a yellow appearance. Microscopically, these tumors are characterized by a proliferation of rounded cells with abundant clear or eosinophilic cytoplasm. Now, very important, the tumors are arranged in the form of sheet. You can see they are arranged basically in the form of sheet and in the form of cords. So you can see diffuse sheets or in the form of cords. You can see long cords you can see. Okay. Now, very importantly, individual cells, they are round. Okay, the round, and the cytoplasm, in some places you can see they are eosinophilic. In some places the cytoplasm is clear. At some places the nucleus will be central. At some places they are at the periphery. Very important thing, that the tumor, that the mitosis is less than 2 mitosis per 10 per high power field. Per high power field there are less than 2 mitosis per high power field. So you can see the ribbons and cords of rounded neoplastic cells with eosinophilic cytoplasm, as we can appreciate over here. Now, the myxoid variety of leiomyoma, as the term suggests, they are basically hypocellular, containing extracellular matrix deposition, which is composed of acid mucin, which is staining positive with Alcian blue. Okay, so these are grossly well circumscribed tumor and they appear grayish and gelatinous depending on the extent of myxoid chain. So histologically, abundant pale blue myxoid matrix is present and it is hypocellular and they lack atypia or any kind of mitosis. So this is the abundant myxoid areas and we can see that they are hypocellular areas. Okay, abundant circumscribed hypocellular myxoid tumor lacking atypia or necrosis. In the end, we are having the dissecting variety of leiomyoma. Here we see nodules of smooth muscle cells which are dissecting the myometrium. Occasionally hydropic changes and intravenous extension can be seen. They are also called cotyledonoid leiomyoma. If the dissecting variety is extending outside the uterus, we are using the term cotyledonoid leiomyoma. Now, the diffuse leiomyomatosis, basically over here diffuse poorly circumscribed innumerous tumor nodules are seen in the myometrium throughout the myometrium. But very importantly, characteristically no atypia and no tumor cell necrosis is there, even the mitotic count is low. It may occur as a part of hereditary leiomyomatosis RCC syndrome. Now, sometimes leiomyomas subtypes may coexist. For example, there might be leiomyoma usual type along with hydropic degeneration. Sometimes they may also show heterologous elements like bone, cartilage, hematopoietic tissue. If you do the IHC, you will see the usual smooth muscle markers like Caldesmon, SMA, Calponen, Desmin, MSA, SM, MHC, ERPR, and WT1. Usually, if you look at the prognosis, the leiomyomas, they have a benign course. Few tumors may recur after myomectomy, very rarely. Okay, young women with leiomyoma with FH deficient morphology should prompt the doctor to look for the HLRCC, that is the hereditary leiomyomatosis and RCC syndrome. Now, this is basically what we have read, and this is classically, if you see, This is the summary of all the criteria that we have already read, and it is very important for you to understand the diagnostic criteria. So the usual type is having intersecting fascicles of spindle cells with eosinophilic fibrillary cytoplasm and cigar-shaped nucleus. No atypia, very low mitotic count. Now the cellular variety of leiomyoma, they are more cellular as compared to the surrounding myometrium or in comparison with the usual variety, but very important. Also thick walled vessels is present over here with cleft-like spaces, but again the mitotic figures are less and there is no atypia, no necrosis. Now leiomyoma with bizarre nucleus will show pleomorphic cells, but very important, the background is that of a typical leiomyoma, low mitotic count is there. Okay, over here less than 5 per high power field and no atypia is there. Now FH deficient leiomyoma, again they are more associated with the HLRCC or the hereditary variety with staghorn vessels, alveolar type edema. They may have bizarre nucleus, okay, large nucleoli with prominent nucleoli and perinuclear halos, as we remember, and with rhabdoid or eosinophilic inclusion. Mitotically active, everything is same like leiomyoma, but increased mitotic activity in the range of 6 to 14 per 10 high power field. Hydropic variety of leiomyoma will show hydropic change or there will be accumulation of edema fluid. Apoplectic variety will show stellate areas of hemorrhage, infarct. Zonation phenomenon will be the history of progesterone or treatment or pregnancy will be there. Lipoleiomyoma will have smooth muscle cells along with adipocytes. Epithelioid variety will have polygonal rounded cells with eosinophilic granular or clear cytoplasm. Now, no cytological atypia and mitosis is less than 2 per 10 high power field. I have made a mistake over here. If you see, basically the epithelioid variety I have told less than 2 mitosis per 10 high power field. Okay, less than 2 per 10 high power field. Okay, it will be per 10 HPF. And also if you see the myxoid variety, they are circumscribed hypocellular with myxoid areas lacking cytological atypia and mitosis. Cotyledonid, now there is a dissecting variety wherein you can see irregular nodular dissection of bland smooth muscle cells within the myometrium, and if it is extending beyond the uterus, it is called as cotyledonid variety. And the diffuse variety, innumerable polycircumscribed hypercellular tumor nodules with no atypia or no necrosis throughout the myometrium. With this, we have completed the uterine leiomyoma and we have discussed in details about the different subtypes along with the criteria. Next, we are going to start with what is called as Stump, that is smooth muscle tumor of uncertain malignant potential of the uterine corpus. Let us try and understand what is Stump. Now, let me just make it very clear. On the benign end or at one end, we are having Leiomyoma, and we have also seen certain criteria for the diagnosis of leiomyoma. On the malignant end, we are having Leiomyosarcoma. Okay, this is the malignant end. Now, what was happening? This is the malignant end. Okay, so now what was happening that there are certain tumors, okay, which are not falling under the category of leiomyoma, and there were certain tumors which were again not falling under the category of leiomyosarcoma. Such tumors were labeled as Stump, STUMP, which stands for smooth muscle tumor of uncertain malignant potential of the uterine corpus. So Stump, if you see, they have morphological features that exceeds the criteria for leiomyoma or its subtype, yet they are insufficient for the diagnosis of leiomyosarcoma, and they behave in a malignant fashion in only a minority of the cases. Three important types of Stump is there: spindle, myxoid and epithelioid variety of Stump. Clinical features are very similar to the patients of leiomyoma uterus. Now they are presenting in the reproductive age group or post-menopausal patient, mean age being 43 years, a decade younger than the age for leiomyosarcoma. MET12 mutation occurs in around 10% of these tumors. Grossly, the features overlap with uterine leiomyoma and some of those that recur have irregular borders. Microscopically, the tumor should have one of the diagnostic criteria for the diagnosis of leiomyosarcoma. And what is the diagnostic criteria for leiomyosarcoma? We are going to discuss in details about the same shortly in the later half of this lecture. Other useful criteria are atypical mitosis, vascular invasion and infiltrative margins. So the diagnostic criteria for spindle cell Stump. Now remember, whatever is the spindle cell Stump, the diagnostic criteria for Stump or the spindle cell variety, it should not be taken as a strict criteria. So what are the diagnostic criteria for the Stump? Tumors with focal or multifocal or even diffuse nuclear atypia, but with 2 to 4 mitosis per millimeter square, that is equating to 6 to 9 mitosis per 10 high power field, and those which are also lacking the tumor cell necrosis. Approximately 12 to 17% of such tumors have recurred. Okay. Now, tumors with only tumor cell necrosis but with no other worrisome features, that means there is no atypia like above, and mitosis is also in this range of 2 to 4 mitosis per millimeter square, or 6 to 9 mitosis per 10 high power field. Okay, these are the second diagnostic criteria for spindle cell stump. Okay, here the recurrence rate of such tumor is 28%. Tumors lacking cytological atypia as well as tumor cell necrosis but with 6 mitosis per millimeter square, that is equal to more than 15 mitosis per 10 high power field, then they are under the criteria of stump, that is the spindle cell stump. No tumor recurrence is seen in this category yet. So these are three important criteria of spindle cell variety of stump. Now remember, this is for spindle cell stump. Now diagnostic criteria for the myxoid as well as the epithelioid cell variety of stump. Okay. Now they are what? Anything more than the criteria of leiomyoma and less than the criteria for leiomyosarcoma should be labeled as stump, and they have to be strictly followed. Okay. If you are thinking about myxoid or epithelioid variety of stump, then you have to strictly follow all the criteria. Okay. This is the basic, criteria which is given by the WHO for spindle cell morphology variety of a stump. As I have already discussed, a repetition where tumor cell necrosis is not present but moderate to severe atypia which might either be focal or diffuse, and mitosis is less than 4, that is in the range of 2 to 4 mitosis per millimeter square, or less than 10, that is in the range of 6 to 9 mitosis per 10 high power field. Okay, over here for the first variety the recurrence rate is approximately 17%. For the diffuse atypia variety the recurrence rate has been seen at 12%. Now in those cases where tumor cell necrosis is present but there is no atypia, and again the mitotic criteria is same, 2 to 4 mitosis per millimeter square or 6 to 9 mitosis per 10 high power field. Here also in this condition, if you see in this condition with tumor cell necrosis, the recurrence rate is taken as 28% has been seen. Whereas in those conditions where there is no necrosis, neither there is any atypia, okay, over here the mitosis, if you see, it is more than 15 mitosis per 10 high power field, okay, 10 HPF, or more than 6 mitosis per millimeter square. In this case, again, this is labeled as a stump, but remember over here recurrence rate is not applicable because that much study has not been conducted yet. This is the criteria for stump of the spindle cell morphology only. Whereas for the myxoid and the epithelioid cell stump, we have to remember only one thing. If they are not meeting the criteria for leiomyoma, then, and if they are also not under the criteria of leiomyosarcoma, then we will label it as myxoid or epithelioid cell stump. Remember, the myxoid and the epithelioid variety, they have a greater chance of recurrence. The mean survival for patients with recurrence is around 5.5 years. IHC markers like P16, P53, Ki67, P21, BCL2, ER, all of these are markers, but they are not used with much success for diagnosis. Now, loss of ATRX and DAX expression along with loss of along with chromosome 5p and 17p gain and chromosome 13 loss, all these are associated with an adverse outcome. So with this we have completed stump, and now we are going to discuss about the leiomyosarcoma of the uterus, or the malignant tumors arising from the uterus. If we see over here, uterine leiomyosarcoma is a malignant mesenchymal tumor arising from myometrial smooth muscle exhibiting spindle cell, epithelioid or myxoid morphology. Now, uterine leiomyosarcomas as a tumor is quite uncommon, representing less than 2% of all the uterine malignancies. But among all the uterine sarcomas, if you see, it does represent most common uterine sarcoma, accounting for 40 to 50% of the malignant mesenchymal tumor of the uterus. Now, there does appear to be a racial difference in the incidence of uterine leiomyosarcoma, with black women being at greater risk for development of disease, and other potential risk factors include use of oral contraceptives and tamoxifen. The median age of diagnosis of leiomyosarcoma is usually in the 5th to 6th decades of life, and the most common presenting symptom is dysfunctional uterine bleeding, pelvic mass and or pelvic pain. Now, uterine leiomyosarcoma, if you see, it is quite an aggressive tumor that has a tendency to recur locally or to metastasize, most commonly to the liver and lung. The prognosis is bad even if the tumor is confined to the uterus at the time of diagnosis. It is seen that tumors less than 5 centimeters when confined to the uterus at the time of diagnosis have a favorable prognosis. Regional lymph node metastasis is not that much common and typically seen only in patients with advanced stage disease. Overall 5-year survival rate for stages combined is 15 to 25% only. Patients in stage 1 and 2, in stage 1 and 2, the 5-year survival rate ranges between 40 to 70%. Despite the differences in survival rate, it is clear that the stage is a significant prognostic factor related to the outcome. The standard treatment is total abdominal hysterectomy and bilateral salpingo-oophorectomy. Response to chemotherapy is quite limited in these tumors. So in this, we have discussed certain clinical features and we have discussed certain basic points along with the prognosis of the tumor. If you look at the molecular genetics, in contrast to leiomyomas, the leiomyosarcomas are characterized cytogenetically by complex numeric and structural abnormalities which may vary from one tumor cell to the next with the same malignancy, suggesting a very high degree of genomic instability in these tumors. Most frequently mutated genes include TP53 30%, ATRX mutation seen in 25% and MET12 mutation seen in 20% of the cases. If you look at it grossly, leiomyosarcoma is typically solitary or dominant fleshy mass within the uterus, is most commonly intramural in location but may be submucosal or subserosal. It has a mean diameter of 10 centimeters. Around 25% measures less than 5 centimeters and they will have a good prognosis. The cut section of this tumor is necrotic and hemorrhagic. The myxoid variety has a gelatinous and friable appearance. So let me just show you this particular diagram. This is the characteristic leiomyosarcoma as we can appreciate. It has a characteristic fish flesh appearance as with any mesenchymal tumor and they show geographical areas of hemorrhage and necrosis as we can appreciate over here. The geographical areas of hemorrhage and necrosis as we can appreciate. Now, although some